Good afternoon. So I'm Nashreen Ozeer. I'm one of the head and neck consultants at Sunderland Hospital. These are my disclosures and acknowledgements. So we've got the post-lunch session, and it's going to be about an hour before we get some caffeine injected in us. Therefore, I've left a few little props in the audience, and audience participation would be much appreciated. So the objectives of today is for us to recognize an airway emergency. This airway is compromised. We want to be aware of some of the common causes of airway obstruction, understand how to manage an unsafe airway, and be familiar with some of the relevant national airway algorithms. So a lot of the acquired upper airway obstruction in adults tends to happen in the region of the oropharynx, the laryngotracheal complex, and the hypopharyngeal area, or even within the trachea or in the upper part of the esophagus at cricopharyngeus. So who's got the tracheostomy tube, please? Fantastic. And could you speak up because age is setting? So can I ask you to give me a couple of examples of causes of upper airway obstruction?
So acquired causes.
Acquired causes, yes.
So trauma, malignancy, infection, supraglottitis or epiglottitis, foreign body.
I should get you down here to give this talk, I think. So yes, trauma-related. I trained in Glasgow. I think I said that last year. And whenever there was a Celtic Rangers match, you were bound to get somebody coming in with some form of trauma, whether it was a punch to the neck or a knife attack with an expanding hematoma. You've covered quite a bit of the infective causes earlier on this morning, I believe. Ludwig's angina, parapharyngeal, retropharyngeal abscesses. But supraglottitis as well is a cause of obstruction. Neoplastic causes, so this is my bread and butter. I'm a head and neck surgeon, so I see a lot of laryngeal, oropharyngeal cancers coming in, and a lot of them will present quite late in my neck of the woods. You will have patients presenting with angioedema, and foreign objects. We'll cover a little bit of that at the end as well. So when we're talking about the history, before I cover the history, can I get you to open that straw and pinch your nose and breathe through that straw for me? Okay. So when we're talking about the history, one of the important things for me is the onset of the symptom. Okay, the onset and the progression of the symptom, because that will tell me whether I need to get the cavalry now, okay, whether I need to get them to open a theatre now, a second theatre, or whether I can wait for the general surgeons to finish their appendicectomy before I sort out this patient's airway. Whether there is any trigger to the symptoms as well. Has this person, are they known to be allergic, and have they taken anything that could have provoked that allergy? And any associated symptoms, a symptom complex together with signs will point you to the right diagnosis. And these are the things that I look out for, whether there's pyrexia with sore throat, hoarse voice, cough, whether they're presenting with dysphagia or dinophagia, weight loss, for example. And a good history about what drugs they're on as well is very important. You might have somebody who has been on ACE inhibitors for a number of years, but they present with angioedema. And if that person that you're about to take to theatre is on warfarin, you want to think about giving them something to reverse that warfarin prior to taking them to theatre, if you've got the time. Social history, a lot of my patients present with stridor in A&E, and a lot of them will be heavy smokers, lifelong smokers, and alcoholics. Okay, so how long did you last? A few seconds. Okay, so you lasted a few seconds, and during that few seconds, you probably found it quite hard whilst you were breathing through a very, very narrow airway. you're finding it difficult to talk to me, okay? You probably were going to start shifting your body and trying to use your accessory muscles of respiration to try and breathe through that tiny hole. You were at some stage going to make some noise, some turbulence of airflow through that little tube that you were breathing through, giving you additional airway noises. Your rests would go up, you become a little bit paler, your oxygen sats might start falling. So these are the things that you want to look out for when you're examining somebody with an airway problem. Thank you for your volunteering. So this is from Hartnick and Cotton. You might have seen this in the pediatric talk. Essentially what this shows is you've got different sizes of airway based on the age of the patient. And you can see how 1 millimeter of edema within that airway can make such a big difference in the cross-sectional area, as well as the resistance to flow of air through that narrowed airway. So if you've got a kid with a 2 millimeter airway, a 1 millimeter edema can cause a 16-fold increase in the resistance of that airway. So this is Poiseuille's law, and you're all probably very familiar with Poiseuille's law. What it shows is the resistance to flow increases the longer the tube is. This is the density of the fluid that flows through, which is why sometimes, if you've got access to something called heliox in your hospital, you might want to give that in addition to oxygen. You've got the radius to the power of 4. Okay, so the smaller the radius of the tube that you breathe through, the higher will be the resistance, and that increases in an exponential fashion. If the cross-sectional area reduces to about 75%, at that stage you will start getting a lot of turbulence of airflow and you get stridor. And the smaller that cross-sectional area, the worse the breathing will get. So this table here summarizes a few of the symptoms and signs that you would expect to see in certain condition, and depending on the site of the obstruction, you will get different types of noise. For instance, if you're talking about severe, huge tonsils, giving you a sort of obstructive sleep apnea type picture, you will get a stertorous type noise. So it's going to sound a little bit more like a snoring type noise. And the lower down you get, you start getting stridulous. And at the level of the subglottis, you will get a biphasic stridor, and lower down in the tracheobronchial tree, it will be more of an expiratory noise or a wheeze. But remember, if you've got a silent chest, this is a pre-terminal sign, because that means that that person is not able to shift enough air through that narrowed airway. So at that stage, after you've done your history taking, and the history taking might be from the patient himself or herself, or if the patient is really compromised, it will be whilst you're doing your examination from somebody in accident and emergency or from the relatives. So at that stage, you're going to decide, does this patient have a safe airway? Does this patient have a potentially unsafe airway? And if I don't do anything now, how long do I have before they're going to lose that airway? Or am I at the stage where I've arrived in A&E and I need to do something now, I need to act now? It is really important to get help early. Get the cavalry there, get the most senior ENT person there, get your anaesthetist there and a pediatrician if it's a child we're talking about. And remember your ABC. One thing that I always say to the new junior doctors starting is whenever you start a shift, make sure you know what the crash call number is. If you've got an airway team within your hospital, an airway emergency team, which we have, what number to call, who's the reg on call with you, who's the consultant on call with you, make sure that you've got all of these numbers already written down and be prepared. So I'm sort of half expecting somebody in the audience to shout out, but you haven't done a flexiscope yet. Okay? So I think that doing a flexiscope is very important, but what if that flexiscope is being cleaned at the moment, it's being used by somebody else? Would you just sit back and wait for your flexiscope to arrive? You're not going to do that, are you? You're going to start instigating the primary treatment measures, okay? So I'm going to ask somebody who's got the face mask. It's somewhere. So could I pick on you then? You had the face mask first. What would you start giving the patients whilst waiting for the flexiscope to arrive? You've got a patient with a compromised airway. What sort of things would you give them?
You started with the oxygen with the face mask at first, but you need to know the vitals as well. So you hook them up to a monitor just to see as well.
Okay. So hook them up to a monitor, give them some oxygen. Gentleman next door, what else would you consider giving them? I did flash the screen before, so you had a sneak peek.
Steroids?
Yeah, steroids will take a few hours to work. Okay. So I've mentioned Heliox before. A lot of hospitals might not have this. It contains a combination of helium and oxygen. It reduces the density of the air that flows through the little hole. Oxygen, give them oxygen. You've got the picture of a standard face mask there. You've got a picture of a tracheal mask for those who've got a tracheostomy or a laryngectomy stoma. But one thing to remember is if you're going to be providing high flow oxygen, over 6 liters, the oxygen tubing is going to ping off them. So you have to use a non-rebreathe mask if it's over a certain amount of oxygen. And you can use a non-rebreathe mask over the face and over a stoma as well if required. Nebulized adrenaline, in my practice, we use 1 in 1,000 mixed with about 5 mils of normal saline. And you can give that back to back if required, because that will buy you some time until the cavalry gets there. We've talked about IV steroids. How much would you give IV steroids? Yeah, around 6.6 milligrams or 8 milligrams, depending on your hospital, and get help. So you've got an airway that's still, yes?
Your epiglottitis, which you'll still see in adults, people forget the antibiotics.
So I'm going to come to that very shortly.
I'd be doing it there.
You'll be giving it there. So it all depends on your history examination and what you've thought about. You're absolutely correct, but we'll come to supraglottitis shortly. So I think one of the things that I want to point out is, as ENT, we're all born with an extra appendage, which is the flexible laryngoscope. But for the initial stage of management, you don't actually need your scope. You can give them oxygen. You can give them all the basic things. And part of the basic things, if you've got somebody who's struggling, is to think about the basic principles, is a jaw thrust, a chin lift, using a nasopharyngeal airway. By the time you get to a Goodell, the situation is not really good because you have to drop your GCS quite a bit to be able to tolerate a Goodell. You've got LMA supraglottic airway devices as well. And if the airway still remains compromised, you need to think about putting a definitive tube, which is an ET or a tracheostomy tube, past the larynx. I'll take this opportunity now to talk about the Difficult Airway Society guidelines. This has been updated in 2015. So if an anaesthetist is finding it difficult to ventilate, intubate a patient, and they get into a situation called can't intubate, can't ventilate, can't oxygenate, so the guidelines, their guidelines, tells them that they have to do an anterior front of neck access. Do you understand what an anterior front of neck access means?
So it's essentially establishing
Okay.
Ideally, tracheostomy, I'm not sure they'd be happy to do.
So I'll go through it with you. I think these are very reasonable answers. An anterior front of neck access, according to their new guidelines, is a surgical cricothyroidotomy, okay? The needle cricothyroidotomy has been largely taken away, and that's because the surgical cricothyroidotomy allows you to put an ET tube down with a cuff, and it's apparently a quicker method of gaining and establishing a safe airway, okay, whilst protecting the lower airway from any blood. So, how do they do an anterior front of neck access? You hold the laryngeal area by using what we call a laryngeal handshake. To me, a laryngeal handshake in anesthetic term probably means an anaesthetist with very shaky hands. So laryngeal handshake, identify your anatomy, find out where the cricothyroid membrane is, and whilst you stabilize the larynx, you use a scalpel horizontally through the cricothyroid membrane, twist the knife at 90 degrees so that the blade is now vertical. You've now left with a little hole, okay, when you're twisting the knife next, adjacent to the blade, and through that little hole, you're going to put a bougie down, and the bougie will curve inferiorly into the trachea. You take the blade out, and over the bougie, you're going to introduce an ET tube, inflate the cuff, connect it up to the oxygen, watch the chest move, and look at the capnography wave. Like we've mentioned, these have essentially been taken off the emergency trolleys, but I think it's always sensible to have this in your armamentarium. And always remember, if you've got somebody who is, for example, in the theatre anesthetic room and they can't intubate, they can't ventilate, and you are next door, okay, waiting for that patient to get wheeled in, you can always use these other equipment that I'm going to talk about to help you. So, who's got the ET tube, please? At the back, fantastic. Have you ever seen one of these before?
Yeah.
Okay.
I haven't seen the procedure though, but seen the instrument.
Okay, and what is it?
It's intubating laryngoscope.
Fantastic. Yeah. So it's an EGA's intubating laryngoscope. The way it works is you introduce it through the oral cavity, you find your larynx, introduce the tube, the Mackling rod ET tube through there. This bit can come off, but you don't have to take it off. And when you're satisfied that your tube is through the vocal cords into the trachea, you can slip this part of the blade of the laryngoscope off, and the whole laryngoscope comes off. So you've secured the airway in that respect. Whenever I have a really difficult head and neck patient, I always ask the scrub nurses to get the intubating negus ready and to get these other instruments ready as well, in case it needs to be open and in case I need to use it. You can consider using an ET tube over a 0-degree Hopkins rod. Your anesthetists are, well, my anesthetists are absolutely brilliant, and they would use a flexible bronchoscope with an ET tube. And once they're happy that the flexible bronch is through the vocal cords, they will push the ET tube down. And even in the context of not really having a big tumor, like some of the anesthetists are absolutely fantastic, and they will always find a little air bubble and get it through. Have your ventilating bronchoscope ready as well. It's got little side ports here, so even if you have an obstruction in the distal area, you can still ventilate patients. And always have a tracheostomy set ready. So I'm going to get you talking now. We've got a few cases coming up. I hope I'm doing okay for time. So maybe we'll start with The lady we've talked, yes, yourself. So we've got this patient, he's 20 years old, he was at his martial arts class, and he was accidentally hit on the neck, causing a bit of bruising, tenderness, and a little bit of hoarseness of his voice. You get called into accident and emergency. Initially, once the injury happened, he was managing to drink, he was managing to talk, but now the voice is getting a little bit worse. He's finding it increasingly difficult to swallow. What's going through your head at the moment? Are you happy to just say, there, take some paracetamol and go home? Or what's running through your head? Sorry, can you speak up? Okay, it's been cleaned at the moment. Okay, so yes, we will request a flexible scope to be brought, but you need to recognize that this is an evolving airway emergency, and you want to instigate the basic treatment that we've talked about before, oxygen, nebulized adrenaline, systemic steroids, because you anticipate that this patient is probably going to have a lot of edema of their airway. If you suspect that they've got a laryngeal fracture, you can start antibiotics as well if it's an open fracture. So always remember to inform the senior people, your registrar on call, your consultant on call, and the anaesthetist. And you get your scope there. You've noted that there's a lot of edema, and this patient, we need to secure their airway, okay? And you need to think about intubation in a controlled situation with or without a tracheostomy. And remember as well that if you're suspecting a laryngeal fracture, once you've secured the airway, you can get a CT scan to look at the degree of fracture and whether it can be managed conservatively. If it's on displays, whether you need to do an open reduction internal fixation. Okay, we've got a second case now. We've got a 56-year-old female smoker who's been unwell for about 3 days with sore throat and a painful swallow. A bit of muffling of the voice, high temperature, tachypneic, mild stridor, and SATs are a little bit on the lowish side, which increased with application of 4 liters of oxygen. This is what you see. So, gentleman who asked me the question earlier on. So, can you describe what you can see?
It's rare that fussy is swollen and the patient would have been contained probably drooling.
Exactly. So we've got edema, erythema, and infection of the supraglottic structures, epiglottitis or supraglottitis. And again, treatment-wise, as we've discussed before, and like you've mentioned, antibiotics in this situation is very important, and we tend to give them in my unit, cephalosporin, and the usual that we've discussed before. Inform your seniors, and for me, if I see a little bit of a milder form of supraglottitis, I would keep them under observation on a HDU setting, and treat them with the medications that we've described. And should their airway go off, they are in a safe environment, the intensivist can intubate them, call us, and get it done in a theatre situation where you've got access to a tracheostomy in case of any problem.
Do you mind if I'm pedantic?
No, be pedantic.
It's got to be a third generation cephalosporin.
Yes, you're absolutely correct. Yes, you're absolutely.
Do intubate and take a swab as well? It's debatable whether it's safe to take a swab if you're not going to intubate the milder ones, which I agree on.
Exactly.
If you do intubate,
Get a swab. And part of the reason that you get a swab is it's not necessarily Haemophilus influenza B.
if it doesn't settle, then you've got.
It could be any of these other bacteria that could cause this. And since the advent of the Hib vaccination in the early 90s, the incidence of this condition has dropped significantly. And we don't tend to see it in children as much because of the vaccination program. However, we tend to see them in adults, and in adults who haven't been vaccinated, and in some children where there is vaccination failure. This is the X-ray that should never have happened. Okay, I got that from somewhere else. It's not one of my patients, can I reassure you? And what you can see on this lateral soft tissue neck X-ray is the thumbprint sign, where the epiglottis is absolutely massive compared to, I mean, you can hardly see it on the other X-ray there. So we'll move on to case number 3. We have a 48-year-old lady of Afro-Caribbean descent who presents with swelling of the lips, tongue, and puffiness around the eyes. You, yes, you. Yes. What are your thoughts? I'm asking anyone who would like to answer. Yes. So the timeline is really important, okay, because that's going to give you an indication whether it is idiopathic, whether it's allergy related, whether it is hereditary, whether it's drug related angioedema. So timeline essential. A history of allergy as well is really important to ask the patient, and what drugs they are on, a family history. So at some stage, 15% of the population will be affected by this, and we've got different forms, okay, different degrees and different forms of angioedema. So angioedema essentially is a lot of edema within the dermal tissue, so it's it's subcutaneous and it's submucosal. If you talk about urticaria, it tends to be in the upper part of the dermis that you get the edema. We've mentioned different forms. The allergic form tends to have a little bit more of urticarial component with itchiness and is histamine or mast cell related. The drug-induced form, about a third of admissions to accident and emergency with drug-induced angioedema tends to be ACE inhibitor related, and that is possibly because ACE inhibitors are that commonly used and commonly prescribed for hypertension. The hereditary form is very rare. We're talking about 1 in 10,000, 1 in 50,000, and tends to be autosomal dominant. The hereditary and the drug-induced form tends to have an effect on the bradykinin pathway, okay? Hence, the reason why the standard treatment, which is what you would give in an allergic type anaphylaxis, I'm talking about adrenaline intramuscular, we're talking about antihistamines and hydrocortisone, don't tend to work in that scenario that well. It might work to a certain degree, but not that well. There's been an international consensus on these hereditary and acquired forms, and what it says is we don't recommend that you use antihistamine, corticosteroids, and adrenaline in those sort of situations. So what do we do then? What do we use? What we use is, you can think about FFP, okay, use of FFP. You can use this thing that I can't actually pronounce. It's a kallikrein antagonist. You can use icatibant, which is a bradykinin beta-2 receptor agonist. So these are not the sort of medication that we would routinely prescribe, so probably best to have a chat with your immunologist about this. Thank you. So we've got another case now. We've got case 4. We've got a 76-year-old gentleman who's a smoker. He presents with 3 months of hoarse voice, dysphagia, weight loss. He was stridulous when he attended accident and emergency, sat to a little bit in the low 90s, raised respiratory rate and tracheal tugging. So you're thinking of malignancy, but we've got somebody with a potential airway problem. So we'll think of the malignancy, yes, but how do we stabilize the airway?
Same way with disease.
Okay. Okay. You're absolutely correct. So primary management, we've given the patient oxygen, some nebulized adrenaline, IV steroids. We've got our senior input coming in. And this is what you see when you do a flexible nasolaryngoscopy. So we've got a bleeding cauliflower. So you can't actually see the vocal cords very well. You don't even know whether they're mobile. You can't really see what's happening underneath there. So further management, the safest thing to do really would be a local anesthetic tracheostomy. And if you've got time, you've bought yourself a little bit of time by giving them oxygen, nebulized adrenaline, etc. You've got time to get them to theatre and not having to do a crash trachea there and then. So one of the things to remember is you might be on call with a senior head and neck consultant who would be happy to introduce a scope through there and intubate the patient themselves, and would be happy to debulk that area without having to do a tracheostomy. But the safest, by far the safest thing to do is a local anesthetic tracheostomy. And afterwards, after you've secured the airway, you're happy, you can then get your biopsies, assess the tumour itself, assess the staging of the disease, get your CT scan, and then talk about definitive management. So how do you perform a tracheostomy? Yes.
Can I just make a really quick point about local anesthetic tracheostomies? So I'm also a head and neck consultant, so this is my bread and butter too. I just think that people sometimes underestimate how difficult local anesthetic tracheostomies can be. And why Nash has just said that as a head and neck consultant, she'd probably do a fibre optic awake intubation if she could and debulk, is because actually often we've seen a situation where you're sort of halfway through a local anesthetic tracheostomy, the patient decompensates, and then you're in a crash tracheostomy situation because you've lost the airway. So for us, we would generally try, if we can, find some other strategy, awake fibre optic, jet ventilation, something else. If you get an airway like this, involve your local head and neck team if you absolutely can, because we'd much rather know about these patients early on.
Yeah, exactly.
Someone be in a situation where they can't get a crash local anesthetic tracheostomy, and which is the time to occasionally be called to theatre.
You're absolutely correct, Hannah. So get your head and neck consultant surgeon colleague, even though they're not on call. You could give them you could even give them a little ring. When are we never in the hospital? So the way to perform a tracheostomy is knowing your surface anatomy. Okay, you've got here the medial aspect of your sternocleidomastoid muscles, your sternal notch, cricoid cartilage, and you want to make an incision halfway between the two. Once you get through the skin subcutaneous fat, you will need to part the strap muscles and lateralize them, and then you're going to encounter your thyroid isthmus. My advice is not to just indiscriminately buzz through it and turn it into a piece of charcoal. You need to take your time, if you've got time, obviously, secure that isthmus properly, divide in the middle, so clamp, divide in the middle, and I would normally oversew it. And at that stage, you're going to get to your cartilage. And if you're not thinking about a high trachea, because you're not thinking about doing a laryngectomy in the future, then use the standard area, which would be the third tracheal ring. If you're thinking this person will likely require a laryngectomy, then do a high tracheostomy so that you can preserve enough trachea so that the head and neck surgeons don't get a bit annoyed with you. We could debate what sort of incision to make for the next hour, but I don't think that's really important. What's important is making a hole into that trachea. And for me, in my practice, I would normally use a vertical incision with stay sutures on either side, or a small window. Show of hands who's still using a Bjork flap? I don't think anyone is. There are cases where patients who've had Bjork flaps have had problems with reinserting the tracheostomy tube, so most people are not using them anymore. And use the appropriate size trachea according to the patient's body habitus. So the same patient now has had an emergency tracheostomy, and you've now changed the tracheostomy tube at day 5. So it's between day 5 to day 7 that we do it in our trust. And after the tube has been changed, everything was fine, and then he started coughing. Cough, 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 cough. This is what one of the nurses who's just started their shift, who hasn't really been working in your hospital, in your unit before, who's locuming in the ENT department, saw, and they thought, okay, that shouldn't be there, and they pushed it back in. So since then, the patient's been struggling, and he's started to drop his SATs. So these are some of the reasons for tube displacement and blockage. Number 1, have you used the correct tube? Always think about the patient's body habitus. Do they have what we call a short fat neck? A short fat neck is you've got a lot of subcutaneous fat between the skin, okay, and the trachea. And the trachea is quite deep into the neck. So in that scenario, you would use a longer tube, you would use an adjustable flange tube, and you would document at what length you have put the flange as well. If you look at this table here, you can see different companies making size 8 tracheostomy tubes have got different inner diameters, outer diameter, and length as well. So be aware of what size tube you're putting in, even though it says it's a size 8. And in our hospital, and I'm sure, and I'm hoping every other hospital have now got rid of single lumen tracheostomy tubes, because these tubes should not be used. And that has been highlighted in the NCPOD guidelines as well on the right track, because they're more likely to get blocked. And if you want to unblock that tube, you have to take the whole thing out instead of taking the inner tube out. Other reasons is that tube, again, the wrong length has been pushed into the tissue, which is anterior to the trachea in the pretracheal tissue, or somebody has not been giving them any humidification and their secretions has become crusty and has blocked the inner tube. I'm very passionate about this. I spend a lot of my time training staff across my trust about how to manage tracheostomy and laryngectomy stomas properly. And I would strongly recommend that you have a read of On the Right Track, which is the 2014 NCPOD guidelines on management of tracheostomy and laryngeal stoma. There is a lot of information as well on the National Tracheostomy Safety Project website, lots of nice videos about how to look after tracheostomy tubes, laryngectomy stoma on a day-to-day basis, but also how to manage the emergency ones. So this is obviously not a patient, it's a mannequin. It's a mannequin with a tracheostomy tube. And sometimes for those who are not used to looking after trache tubes and laryngectomy patients, it's quite difficult to work out whether it's a trache patient or a laryngectomy patient. And this is really, really, really important. It's really important because it would be absolutely fatal if somebody got called for an emergency and thought, this is a trache patient, not a Lary patient, and stuck oxygen on their face and forgot to put oxygen onto their stoma area, in which there's a tracheostomy tube. Remember, a lot of laryngectomy patients, or most laryngectomy patients, don't have any form of tubing that we put in their stoma, but sometimes you might have a tracheostomy tube if they've got a leak, if they are immediately post-op and you're worried that blood might be trickling from their pec major flap that you've put in down into the trachea. So absolutely crucial to be able to differentiate between trachea and Lary. Handing over is very important. Am I overrunning? Severely overrunning. Okay. So I'll let you have a little read through this. Handing over is very important, and also ensuring that the patient has the appropriate bed head signs at next to their bed, so that people know that they are a tracheostomy or a laryngectomy patient. And all of the patients should have an emergency algorithm next to them as well, and also the appropriate box with the appropriate equipment to be able to sort out any form of emergency related, any form of airway obstruction related to a tracheostomy tube. So given that I'm overrunning, I'm just going to skim through the laryngectomy bit. You can read that up on the webcast, and you can go on the National Tracheostomy Safety Project, and there's our important resources for you to go through as well. So last, airway foreign body, important to recognize them and important to know how to remove them. And I love this little instrument. It's an optical forceps. You can put a Hopkins rod through it, insert it through the trachea main bronchus to remove foreign objects, or you can use a rigid bronchoscope. Why is a swallowed pound coin a potential airway emergency? That's because this little kiddie who swallowed this pound coin, which is sitting in the cricopharyngeal region, could regurgitate that. It could fall into the airway. So that's the end of the talk. Just to summarize, make sure that you focus on the A of ABC. Give the appropriate primary treatment and use airway adjuncts, and think about securing the airway early and consider surgical airways and call for help very early on. Okay, thank you very much.